I am Admiral Rachel Levine, the Assistant Secretary for Health at the United States Department of Health and Human Services. I am glad to join you for the inaugural Syndemic Solutions Summit. Healthy People 2030 defines health equity as the attainment of the highest levels of health for all people. This is a critical element to finding effective solutions to a complex syndemic that is made worse by social and structural drivers of poor health, such as discrimination, stigma, and inequality. Achieving health equity requires valuing everyone. That means making focused and ongoing efforts to end inequalities, eliminate the impacts of injustice, and improve the health for everyone. As we seek to address the syndemic of HIV, STIs, viral hepatitis, substance use, and mental health disorders, as well as reproductive and sexual health, it is crucial for us to work collaboratively across federal agencies. We also need to be in lockstep with engaged individuals, communities, and groups outside of the federal government. In addressing syndemics, we must do the hard work of understanding and centering the varying needs of communities all across the United States. We must identify avenues to empower individuals to have a hand in shaping the public health agenda and defining the future in which they desire to live. We must emphasize the need to integrate programs to address the syndemic in the context of social and structural institutional factors, including stigma, discrimination, and violence. We now have a much clearer understanding of the factors that foster risk for acquisition of these diseases, as well as those that improve or inhibit health outcomes for people living with them. Many of these are rooted in the social determinants of health. These include factors such as income and employment, stable housing, and adequate food and nutrition, as well as education access and transportation. There are also structural barriers to optimal access to health services, such as laws, policies, or practices that perpetuate stigma and discrimination, or limit availability of evidence-based interventions. Now, some of these policies on the books may have had some good intentions originally when they were put in place 10, 20, or more years ago, but this is 2023. We need to have an in-depth review of these policies to make sure that they are not inflicting harm or serving as barriers to our efforts. We also need to work collaboratively to identify and address funding, policy, data, and workforce capacity, as well as programmatic barriers to effectively address this syndemic. Obviously, no single agency or organization can lead all of the great work and activities occurring at the local and state levels. However, if we work collaboratively and continue to seek and build new partnerships, we may be able to reach a guiding vision and find creative solutions to this syndemic. I am certain you will have some of these discussions over the course of this event. I hope you will continue that dialogue even after this event takes place. Today, you will hear from leadership across the federal agencies about how each of them is mobilizing syndemic approaches in their fields and jurisdictions. I hope our collective experiences will shed light on the fact that while there are challenges, there are also opportunities to work together in ways that are innovative and essential. Over the next 2 days, all of you have an opportunity to do just that. Come together to view these 5 critical health priorities from a syndemic lens, and I know you will. I will conclude by expressing my sincere gratitude and appreciation to each of you for the work individually and to all of you for your collective work that has gotten us this far in addressing the syndemic of viral hepatitis, HIV, STIs, substance use and mental health, as well as reproductive and sexual health. Our shared responsibility now is to continue to enhance and intensify our work in the months and years ahead. Now, I am a positive and optimistic person, and I believe that working together, we can create a better future for all living in the United States. And now I am hopeful for a more inclusive future because of the work that all of you are doing every single day. Now, it gives me great pleasure to turn things over to my dedicated colleague from the Center for Disease Control and Prevention, Rear Admiral Jonathan Mermin.
Well, good morning, and thank you for the welcome to Admiral Levine. And I wanted to start off first just by appreciating the moving and meaningful messages from Carol Cadu Blackwood and Angel Boland Chappell and Kelly Reinhardt and others this morning. I think it really sets the stage well for my talk and all the panel discussions that are coming up this morning and tomorrow. I also wanted to thank the team from CDC that's been working on a syndemic approach for many years, Michelle Van Handel, Cecily Campbell, Sharanjit Sagu, and others that aren't here, and then people in the ASH's office and other parts of both the US government and nonprofits throughout the country who've been thinking about how this approach can be most effective. So I will start off by, I'm gonna think, kind of put a lot of time into some background information about some of these epidemics, some thought processes about how to approach a syndemic public health approach in our work, and then leave some time ideally for some questions or comments from the audience. But I wanted to start off that Kelly Reinhardt and the octet did not pre-approve this talk. Okay. So first, just for HIV, just for background, so there are about 1.2 million people in the United States living with HIV. And there are certain characteristics of the epidemic. One is that people with HIV who are virally suppressed do not sexually transmit HIV. So being diagnosed and on treatment not only helps you live a long, healthy life, but also prevents you from transmitting HIV to others. In addition, pre-exposure prophylaxis, or taking a pill a day, or an injection once every 2 months, is about 99% effective at preventing acquisition of HIV. So we have some powerful tools to prevent either transmission or acquisition of HIV. That exists within a framework of major disparities. So African Americans, who are about 13% of the country, make up 40% of people with HIV. There's also disproportionate prevalence of HIV among Hispanic and Latinos, and also gay, bisexual, and other men who have sex with men and transgender women are over 100 times more likely to have HIV than heterosexual men and women. So we have this kind of epidemic ensconced in a society that, because it's unequal, without extra efforts to try to prevent disparities from occurring, those inequities will naturally occur. Even within that framework, over the past few years, we've seen some signs that HIV prevention has been working. We've had a 12% reduction in HIV infections in the past 4 to 5 years. And because of that, we've saved over $15 billion in healthcare costs. So I wanted to highlight that HIV and many of the other infections that we're talking about over the next 2 days, they're expensive for the healthcare system and for society. And because of that, good prevention saves lives and saves money at the same time. So just to touch on viral hepatitis, I have one slide for each of our major hepatitis. One is hepatitis A. We starting about 5 years ago, started to have a major epidemic of hepatitis A, primarily affecting people who are experiencing homelessness and people who use drugs. This spread throughout the country and required an enormous response from health departments and communities to be able to bring vaccination to people who needed it. In the end, well over $200 million of healthcare costs were experienced primarily by state health departments and their kind of Medicaid programs. And that was that occurred even though hepatitis A is relatively rarely occurring in the United States except in these populations. And we can talk about why that is, but some of it is that not everyone has been vaccinated. Hepatitis B is also a prevalent infection in the United States. We estimate there are about over 800,000 people living with hepatitis B. It's vaccine preventable, and so most of the people who have hepatitis B in the US were either born outside the US or their mothers unknowingly had hepatitis B and passed it on to them when they were not vaccinated. Over half of people with hepatitis B don't know it, so it's considered somewhat of a silent killer because people often have severe liver disease or liver cancer by the time they find out that they have it. And then hepatitis C is another kind of infection that causes hepatitis and liver cancer. It's very common. Many people in this room have been working on hepatitis C because it primarily affects people who have injected drugs, especially more recently since we've been able to screen the blood supply. It costs billions of dollars each year, but it is curable with 8 to 12 weeks of oral therapy. That therapy, when it first came out, was extremely expensive, over $100,000. It's now down to closer to $20,000. But a lot of the restrictions that were put into place to try to prevent people from accessing treatment because it was expensive are still in place in many states and in many private insurers. So people are dying of hepatitis C in the United States because they can't access treatment that justly they should be able to access. And then STDs have also been increasing since 2014. We've had year upon year of increasing STIs in the United States with over 1.5 million cases of chlamydia, over 700,000 cases of gonorrhea, and then close to 200,000 cases of syphilis. And these are very costly, as I said, to the healthcare system, but they also have other effects, not just for increasing the chance for infertility in women, but also increasing the chance that you will transmit HIV or acquire HIV. And then lastly, I mentioned TB, although it's not a focus of this conference. There are over 8,000 cases of TB in the country, but in many ways, TB also represents some of the opportunities and challenges we have in our other kind of epidemics that make up our syndemic, because there are about 13 million people in the US who are living with latent TB infection. In other words, it's in their body, they don't know it, and it has about a 5 to 10% chance of becoming active TB disease in their lifetime. There are new treatments that are short course compared to older treatments that took months. And there's also a shorter course treatment for TB disease, yet we still continue to have infections of TB. So now I wanted to say, kind of after that background, just kind of how are we thinking about syndemics and a syndemic approach? And I wanted to just highlight that this is the best kind of definition we can think of for a syndemic. It's 2 or more diseases or health conditions that are clustered within a population. Social, epidemiologic, and biological factors create conditions for that clustering, and they result in adverse disease interactions and increase the health burden for the affected populations. And so these kind of are population-level clustering of social and health problems. And I wanted to just stop there and say that's the last time I'm going to try to define a syndemic, because I don't even understand this. Like, I mean, first of all, is it a syndemic when it's multiple infections and social causes at once, or is it syndemics? And is it plural? Is it singular? How do we cope with it? And no one can really answer it, but we all know what it means. And I feel like I'm going to put this aside for this talk and move on to the next slide, which says all of these social and structural factors are influencing our infections, the infections we're talking about today and tomorrow. And what I want to do is move into the idea of what is a syndemic approach. How do I use the concept of syndemics? Not trying to argue whether they're synergistic, and hence the word syndemic, or additive, or anything else, but just that they influence each other. There are all these different factors that make a difference, and that we have opportunities to leverage different points along the kind of the syndemic system to make a difference. And the first would, what if this is true? If we can do a good job, what are some of the benefits to a syndemic approach? Well, first, efficiency and cost effectiveness. If you do this well, you should be able to do a better job. You should be able to increase flexibility and responsiveness so the people who are providing services are able to respond to what their patients or clients need, and the people who need the assistance or services are actually able to acquire it at one single place instead of having to go to multiple places. It's a holistic provision of interventions and services, and if you think through this lens, often you can't help yourself from moving upstream and thinking, how can I kind of change something more upstream, whether it's reduce discrimination, increase access to services, change policies and laws, something that's going to have a broader effect. Because instead of thinking about just one infection, I'm suddenly thinking more broadly about populations. And I will say that for me, a lot of it, I'm a primary care physician. I did residencies in internal medicine, primary care internal medicine and preventive medicine. And I was proud that I cared about the holistic aspects of a patient's health. Like, I thought about it, like, what about their home? What about their family? What about multiple different illnesses? I kind of think of a syndemic approach as that on a public health perspective. Something that here at a nursing school, everyone would understand. I want to be able to respond to the population's needs, understanding that it's going to depend differently for different people and different populations, instead of being siloed from one approach. So why is this such an issue now, and why are we talking about it? I think one is that there are restricted budgets, and that will probably continue for the next few years, which means that we have to do better with the resources we have. The second is there's increasing demand. I think the populations that we work with who are affected by our infections, they're asking us to do a better job. They're asking us to be thinking about their health more in general instead of very specific disease-focused areas. And the other is that there are new tools and data that I'm going to touch on that really lend itself to us doing a better job with a syndemic approach. So this syndemic framework, we tend to think about it at CDC right now from 4 different perspectives. One is people, the other is place, either geographic or venue. The third is policy, and then the fourth would be science. What science can help us along the pathway? So first, to start with people mattering. Essentially, there's differential incidence, morbidity, mortality for all of these infections, and they're frequent and they're frustrating. And in some ways, it's the injustice of health disparities that drive us to care. These inequities, however, are not inevitable. And although I don't have slides here, in some of these infections, we've been able to dramatically reduce some of the disparities that have occurred since for decades. And in others, we are still challenged. Communities benefit from comprehensive approaches better than they would with siloed approaches. And strong partnerships can improve outcomes. And I think that partnerships with multiple different aspects of people in this arena is going to be a theme for the conference. So everyone is affected by these infections, but not equally. And I'm just highlighting that disparities kind of drive a lot of the approach for syndemics. One is persons born outside the US are at higher risk for hepatitis B and TB, particularly people born in Asian countries. Whites and American Indian Alaska Natives have the highest incidence of hepatitis C. Youth experience 46% of new STIs in the country. LGBTQ adolescents are at higher risk for experiencing violence, suicide, and depression. And as I had mentioned earlier, MSM and transgender women are at high risk for HIV, but also for STIs, Mpox, and experiencing homelessness. African Americans and Latinx and American Indian Alaska Natives have a higher incidence of TB, HIV, and STIs. And all of these infections are associated with income, employment, and housing in positive and negative ways, depending on your perspective. So thinking about this can allow us to be more efficient, to reduce disparities as we do a better job with providing our services and measuring whether we're making a difference or not. So place also matters. So this is there are disparities in geographic distribution and resources. I'm going to show some maps. There's social and economic determinants that lead to most of these disparities, and they vary by place, where you live, where you visit. We should align our resources to the disease burden. That is hard to do, but often not done very effectively. And we should co-locate services so that we can provide the holistic care that we talked about earlier. And I just wanted to show a map. So there are about 3,300 counties in the United States, depending on how you count. And these counties in blue on the left are the counties that have the highest burden for HIV, chlamydia, gonorrhea, new HBV, new HCV, syphilis, and or TB infections. So essentially, they cover about 50% of all of the cases of these diseases. And this is a very small proportion of all the counties in the country. So why? Well, a lot of people live in some of those counties. But also, even taking account for population density, we also have higher rates of infections. And I think it's important to think that we don't have to do everything everywhere. But what a syndemic approach does is asks us to put our resources where our epidemic is. On the right are the EHE jurisdictions in dark red. These are the local jurisdictions, the 50 local jurisdictions that have about 50% of HIV infections in the United States, and they overlap with the other map of all these infections. So it's not complete, but I would say that at a national level we have to think about this, but it also matters at a state level. Where in your state are you putting your resources and focusing your efforts? And then within your city, where are you putting your resources? What neighborhoods need the help or need the services to be provided? Where are your PrEP clinics being placed, where your STI clinics, where your syringe service programs. Are they where people need them, or are they where you could find a place to put it, or where someone else was loud enough to get it? All those things can come into play, but thinking very carefully about where we put how much place matters can help us do a better job. And that just leads into the kind of, the place also matters for venue or service sites. So what areas do we need to have those services so that people can get this comprehensive care? One is integrate screening for those infections that we just talked about in emergency departments, in inpatient settings where you're already drawing blood anyway, and in community health clinics. Syringe service programs clearly are one of the kind of prime sites for a holistic service provision, whether it's substance use, mental health, sterile injection equipment, wound care, HIV and hepatitis C screening and treatment. STI clinics, great places for people who get STIs to also get HIV care, but also get other services, community-based organizations. I will say schools in many ways, and I will say correctional institutions, there's some similarities between the two. Schools have a captive audience, and you can provide services much more efficiently if those services are of high quality. Same thing for jails and prisons. Home telehealth and self-testing is also a mechanism, instead of doing just one disease, thinking about how I can have a holistic approach. And then we can provide services in other special places like bathhouses and similar venues. I also want to touch on just that the science matters too. So, the technology that we produce is going to lead us down a pathway for a syndemic approach, better or worse. So if you have a multi-pathogen testing, for example, something where I can do HIV and syphilis at the same time, or what we're working on and close to being available would be a point-of-care test for Mpox, syphilis, herpes, and VZV, so that you can differentiate and figure out right then and there what someone has as a kind of diagnostic tool. If that doesn't exist, it's both more expensive generally and much harder to actually have the syndemic approach that we want. Multi-pathogen vaccines prevent infections. So again, we often if you have one vaccine, that hurts. People want to avoid it. But now I have another vaccine and another vaccine. Well, what if, like measles, mumps, and rubella? It's a single injection that has 3 different vaccines there. And so there's a big movement into trying to get a combination of vaccines together. What would that mean for us? PrEP guidelines. Our PrEP guidelines that gives some information, clinical guidance for practitioners on how to provide pre-exposure prophylaxis for HIV. Those guidelines incorporate a syndemic approach. They recommend that people get STI screening every 3 months. At the same time, they also recommend being screened for viral hepatitis and before you start PrEP. And because the U.S. Preventive Services Task Force has given that a Category A recommendation, it means it's covered by the Affordable Care Act. So almost everyone in the U.S., not everyone, but almost everyone should be able to get PrEP and all those other ancillary services, laboratory tests, as well as support for taking their medication with no copay. And then syringe service programs, as I mentioned before, they have multiple effects. So in some ways, we're asked then to look from a scientific standpoint, where do we need innovation along that continuum of public health? And I would just ask that a lot of people we're at a university, people are thinking about research. Sometimes we're naturally drawn to operational and implementation research because that's kind of our space here. But also just to think about, if my research is finished and it found a positive result, would it make a difference? Is this the most important thing that I should be doing now? Or is it something that I could get done because that's where the funding was? And I think I would push people to continually ask themselves, along that continuum from applied research and clinical trials to operational research to policy change, there are examples of the things on the right where all of those things have different spaces along that continuum. And just let's continue to challenge ourselves to do the best we can, because we're drawn to this field because we want to help people live long and healthy lives. And then I wanted to touch on policy because, again, this is kind of often at upstream, but it can also be midstream, or that nexus between the federal and the local level, as Kelly had mentioned earlier. So one is policy can maximize our reach and effectiveness. Often we think of money and what we can do to run a pilot program or a research study or to support a program that's already existing to do a better job. But policy can sometimes, by changing that, can either take away a limitation or can put something in place that could have a broad-reaching effect. Good policy can be cost-saving. Policies can act upstream and can improve health equity in ways sometimes that we can't do it at the more distal level. And policy and law can often provide long-term solutions. I'm not naive enough to say that forever, but I do think it's hard to change some entrenched laws that are good, and it's hard to change them that are harmful. And we should try to continue to put in the good ones and take out the bad ones. So now I just have a few examples to kind of spur the thought process along. So one is administrative flexibility. Anyone here who's received a grant from the state, county, or federal government, raise your hand. Okay, good. So was that fun? Right. So it's tough when we have these siloed approaches. They also mean that you can sometimes measure difference better, but we need to figure out from a measurement standpoint how we can make it easier to get the information necessary to know that we're making a difference, and also make it a syndemic approach more viable for the actual practitioners. I just wanted to give an example that in the US, 38% of people with Mpox also had HIV infection. This is about 30,000 people who had Mpox in the US. A high proportion were also diagnosed with STIs in the past year. And people with Mpox and HIV-associated immune suppression were also more likely to be hospitalized, and almost everyone who died of Mpox had HIV, poorly treated HIV infection. So we had a need for a rapid response to an unanticipated outbreak. And so the federal government was able to put out administrative flexibilities through Ryan White, through CDC, and through SAMHSA that allowed funding for Mpox using a syndemic approach so that we could immediately use our disease investigation specialists to be able to help out with the response. And our communicable disease staff could also work on the response, and we could actually share information across those often siloed approaches. So the question is, what would we need to do in the long run to allow this to occur? Syringe service programs. So I already talked about that. I think they're natural places for effective syndemic approaches. SSPs are associated with about a 50% reduction in HIV and hepatitis C infections, and when combined with medication for opioid use disorders, referral for MAT, there's over a 74% reduction in infections. Clients who use SSPs are 3 times more likely to stop injecting. Naloxone distribution through SSPs is highly effective in reducing overdose deaths. And there's an opportunity for all these other services that we talked about earlier: vaccination, clinical care, hepatitis C treatment has been provided through syringe service programs. You can provide people with medication, they come back once a month, they get a refill. And there's very strong data. I have some examples from Philadelphia, but there's data that it's cost saving. Here, the SSPs are estimated to have averted over 10,000 HIV infections over 10 years with a 1-year return on investment of $243 million. That's a lot for a city. So I think there's a dream that my team and I have talked about, which is to have syringe service programs a normal part of public health in the United States. So just like you'd expect that if I'm going to have a county health department establish services, I'm going to have a TB clinic, I'm going to have an STI clinic, I'm going to make sure there's federally qualified health centers, I should also make sure there are syringe service programs in the places where they're needed with comprehensive services and supportive funding. Okay, another example is CDC has a program where we fund educational institutions about called What Works in Schools. And this is focused on creating kind of holistic, safe, and supportive environments, quality health and sex education, and increasing student access to health services, either at the school or referral to kind of adolescent-friendly health services close by. And this in a very nice ecological study was shown to have substantial reductions in students reporting that they'd ever had sex, that they had 4 or more sex partners, that they missed schools because of safety concerns, that they've ever been forced to have sex, or they ever or currently using cannabis. So there's broader outcomes, health outcomes, from a comprehensive intervention at the school level. And then I'm also going to say that I think outbreaks also provide us with an opportunity for having an integrated response that kind of looks through a syndemic lens. So we have had many and continue to have outbreaks of HIV and hepatitis C among people who use drugs, often in either semi-suburban or rural areas of the country where the health department services are extremely limited and the community-based organizations may not even exist. And so the question is, how do you approach that in a syndemic way? Well, you have to think about it first with embracing the entire community, asking people to bring in their friends to make sure that they know that there are services available, make those services comprehensive with social workers, with HIV and hepatitis C testing and treatment. We often have to establish HIV or hepatitis C treatment in the community that might not have had it already, making sure there's some kind of sustainable supply of sterile injection equipment and SSPs, ensuring that people have access to substance use and mental health services, maintaining or initiating STI screening and treatment, and then often enrolling people in Medicaid can make a big difference because they won't have been, and then naloxone distribution. And so we've been most effective in these types of outbreaks where we've had that comprehensive approach. But I will say it also takes a couple of years to be able to do this. And often when the kind of excitement of the identified outbreak fades, so do the resources. But we also have other examples where if you come in more comprehensively with a syndemic approach, you can be more effective in your outbreak response. And then I just wanted to say that the most upstream, or almost the most upstream, for us would be Social Security, Medicare, and Medicaid. So the introduction of Social Security was associated with large decreases in poverty and mortality among older persons in the US. We don't remember those times, but it was a tremendously different era where the majority of people who were experiencing homelessness in the US were older, and where a lot of the environment was that people couldn't afford essentially to grow old. Medicaid expansion has been associated with improved health outcomes related to HIV, to cancer, to maternal and neonatal health, and reduced health disparities. And Medicare is associated with reduced mortality, hospitalization rates, and healthcare expenditures. And I mention these examples just that at some point that matters a lot. And someone's thinking at that level, we need to make sure that our infections and the communities that we care about are included somewhere along this pathway as those are implemented and thought about. But also, we need to recognize that for all that we do at the distal level, often with specific programs, if we just change the health care system or health insurance system in America, we would be better off. So lastly, this is like what's prevented a syndemic approach in the beginning, and I would say that this is both from a negative perspective, but it's also from a positive, because these can be changed. One is organizational structures and funding silos. So we just need to think about it. What would we need to do to change so that we can work together better, and that there's some more flexibility in being able to use resources to be able to succeed in this endeavor. We have multiple surveillance systems, and CDC is spending a lot of time trying to change that world, to both modernize surveillance, but also to make sure that as much as possible there's a standardization so that kind of siloed surveillance doesn't prevent people from recognizing that a syndemic is actually occurring in their community. We have to think about communication and programmatic parsimony. And this is just, I'm just thinking this way, like, we have campaigns. We have a lot of campaigns. There are national campaigns, local campaigns. They can be digital campaigns. They can be, online, Grindr-based campaigns. We have campaigns, but are we thinking from a syndemic perspective, or we have one for, let's say one infection and then another infection, and then another program, and how do we kind of join them together and make sure that they're still effective? And I think programmatically that also occurs. Are we reaching out to our partners when we get a new grant and we're doing a program that's going to benefit our community, or are we thinking more about just our own assigned tasks? And then I also think that one of the things that's prevented us from moving forward has been a fear of mission drift, that people who are responsible for public health or for resources for public health are concerned that if they allow complete flexibility, that people won't be doing the work with the communities that we care about the most, because those communities can often be challenging to work with, or the systems make it challenging to work with them. And so people could wander, and we don't want that to happen. So just my last slide is just to say that kind of some key policy actions to kind of address our syndemics in a proactive way would be putting people first and populations first, to focus on equity at all times. I think this is a critical aspect of whether we're going to succeed or not, is both thinking about it in advance and measuring it, and then adjusting as needed to make sure that we're making a difference. Put money where your epidemic is and don't shy away from that. It's probably the hardest thing politically when you're trying to make decisions when it comes, is making sure that money goes to the communities and the geographic areas that need the resources the most, because it's easier not to do that. We need to leverage policy as a public health tool more and more. I think I was delighted that at least one of the octet is an attorney. We need to think about what that means. Like, how can we use the experiences with law and policies to be able to make a bigger difference? And then support workforce and partnerships, because they matter as well. So that's it, I think, for my slides. And I don't know if there's any time for questions.
Thank you, Dr. Mermin. Thank you, Dr. Mermin. We can open it up for questions. We have about 30 minutes for some discussion and questions, and we have some microphones out in the audience. And maybe we can go ahead and get started with that?
Great, that's perfect.
Yeah, great.
Thank you.
So Dina and Steph are out there. There's Steph to your left, my right, and there's Dina, your right, my left, with the microphone, and we'll look for some questions. And Dina, I think we have a question up here at this table. Thanks.
Good to see you again, Dr. Mermin. One of the slides was about people's matters, I believe, and I love the ones that you share. I believe was people matter, places matter, science matters, and policy matters. On the people's matters, I can recall if you highlight how culture, race, and ethnicity define people. If you could elaborate on that, I will appreciate. And again, amazing presentation, and thank you for your work, you and your team. Thank you.
Thank you very much, and thanks for all your work applying this approach in New York City. I think that, I didn't emphasize that on the slide only because of time, but even what we define as people, groups, and populations varies. And it matters a tremendous amount. Culture matters. And when we talk about, for example, we talk about race and ethnicity, there are multiple different races and ethnicities, different ways that people identify, and the effect of that in your community can vary. I think I had one data point that Asian Americans, who make up about 5% of the country, make up 40% of the people with hepatitis B and tuberculosis. And that's a tremendous disparity that's not talked about much outside of that field. But it's not all Asian Americans, and it's not Asian Americans from all countries, but we have a tendency to define what race is in the United States and what ethnicity is, and then to use that. And it can be a tool for identifying both where you can focus your efforts and to calling for kind of more equitable systems and health, but it also can confine us. And so I think just having a flexible and thoughtful perspective, the way you're describing it, could really help.
Thank you, Dr. Mermin. We have another question over here.
Hi, thank you so much for your presentation. I just want to say it's really powerful to hear you talk about syringe service programs in this way as someone who's done that work for a few decades. And I'm curious, nationally, knowing the policy landscape of many states still not having legal syringe access, not having those programs exist, what your approach is to making sure we both have the policies, funding, and structures to really support expanding those programs.
Great, thanks. Could you introduce yourself, sir?
Oh, yeah. I'm Savannah O'Neill. I'm a consultant with Vicente Consulting out of California and worked with Laura Guzman, who you'll hear from later, doing national harm reduction work.
Fantastic. Thanks. So we've spent a long time thinking about this, and really for almost a decade have been thinking about what different leverage points can expand syringe service programs in the U.S. So some of that was just collecting the data, and using the voice of hopefully the still respected Centers for Disease Control and Prevention to be able to say that we've evaluated the data carefully, and these are the potential benefits, these are the costs and the potential cost savings, and these are the questions that still are extant. And then to take that and then move to the next level, which is what would a comprehensive program look like? And thinking about syringe service programs, if just like you would other public health interventions, you can have I'll just say like a tier 1, where it's just basically sterile injection equipment, some basic care and referral to services. But you can also have a tier 2, which expands more beyond that with HIV and hepatitis C screening and maybe naloxone distribution. And then you can have these comprehensive things. And you need support all along the way to do that. So one was just to kind of have some guidance, and we worked with NASDAT and others to develop guidance that could help think about what are some of the things I'd want to get done if I want to start it. We also have technical assistance now that can be requested for developing a new SSP or expanding my SSP, or even some of the administrative services, and maybe even getting some grants. There's just ways that a lot of these programs, because they grow from the grassroots, have unique needs and desires that is maybe different from a federally qualified health center or a clinician who's wanting to provide people with PrEP. The other area is to share information publicly, both in talks but also in papers, to work with policymakers. And we have had learning labs where we actually bring different states together to talk about this and to think about what they would need to do if they did want to address SSPs and maybe adjust some of their regulations to make it easier for SSPs to exist in their jurisdiction. And so it's always from the basis of treating it just like we would treat a TB clinic or something else, that if once you take out the stigma and sometimes discrimination associated with how society treats people who inject drugs, and you normalize that care the way you would other care, suddenly you see all these opportunities that could happen. So this is a work in progress. We appreciate what you're doing in California, and many people in the room. And I know that a lot of this kind of harm reduction world is kind of invigorated by the PWID community. And so we are continually trying to expand how we're able to assist those efforts and to learn from that with some of our other communities.
Thank you.
We have one over.
Okay, hello. My name is Dr. Thea Walker. I work with SAMHSA, the Center for Substance Abuse Prevention. And so we were wondering, what's the role of substance abuse or prevention in this syndemic approach?
I think there's a tremendous amount. You could kind of take every single slide and envision how substance use can play a role, and substance use treatment and mental health services, which are overlapping but not all the same, could also make a difference. I'll say that it can vary from something like our team did a study that showed that that taxation on alcohol, if there's an increased cost of alcohol, it's associated with a decreased incidence of gonorrhea in your state. So it can be something like that. It can be also just making sure that you have referral to services and making it easy so it's not a long wait, because long waits are difficult to cope with. It could be situations where you try to destigmatize substance use in mental health, or that certain laws that criminalize possession of drug paraphernalia, for example, can make it harder for people to access services and actually harm their health. And so there's ways that we can look at that. We can examine the science or collect the science that's been conducted by others, talk about how we can change our policies. And I think SAMHSA has some really creative programs and funding that's actually been able to try to integrate substance use services into the syndemic approaches that we've been talking about.
Thank you, Dr. Mermin. We have two over in this corner, so I'll start here and then go over there. But I'll hold this for you so you can just, yeah.
She's got a camera on me. Okay. Hi, my name is Patty Martin, Institute for Social Health, SAMHSA up front, substance abuse prevention, 30 years in the field with you guys. But my question is about your surveillance data. So what are you all doing, where are you headed in providing surveillance data that will help us identify and then address syndemics?
So So I think there's a variety of different ways. One is just doing the kind of maps that we're talking about, but then working with our jurisdictions to make those maps even more detailed. So it can be helpful to know that a county is more likely, for example, to have multiple and kind of increased rates of our infections, but it's really helpful if you know the neighborhood, and that you know the services need to be provided to that neighborhood. And when you're thinking about, for example, routine screening in a hospital, which hospital are you picking? I don't know Kansas City very well, but I imagine that there's hospitals where you'd want to establish it faster and better and more routine than in other hospitals. And so there's one way that just being able to work and that those data can be combined and looked at. They can be, but they're often not, either because of the silos or because we haven't done that. So Michelle Van Handel, who's in the room, has been spending some time thinking about how we can help make that easier for jurisdictions so that they can do that. The other is just the surveillance itself, that often when you're in the health department, it's difficult to actually get permission to kind of look across some of the silos of data, and so we should be able to do that as well. Is there something specific you're thinking of? You have your hand up.
Real quick, sorry to monopolize. So on the CD website, maps are currently available that are addressing multiple issues within county-specific levels across the nation.
That's correct. Our atlas.
And you're going to continue to provide those as the data becomes available. Okay.
Oh, yes, I'm sorry. I should advertise Atlas. So if you want, I'm sorry. So sorry, Michelle. So yes, so we actually wanted to make data available to people so that they can access it very easily. And so we have an Atlas Plus website, if you go there, and you can stratify your data by year, by age, by jurisdiction. You can look at that. We also have had some social determinants of health data that can be mapped on top of that. And then we also have a widget for our youth risk behavioral surveillance system, which is the surveillance system that asks questions of students, mostly high school students, in the United States every 2 years. And so that also is available for exploration if you want more detailed information. So yes, from the comfort of your home office, you can actually look at these data too.
Thank you for your wonderful presentation. I'm Sally, and I work in the area of culture and DEI. And so as we look at the DEI, anti-DEI movement that's occurring, and I listen to what you're presenting, I'm hearing a lot of stigmatism against funding and et cetera, and that there's a parallel between Syndemic and the anti-DEI movement. So would you be able to address how we pull these things together, perhaps, and expand? Because there's a lot of stigma with all of these diseases, and there's a lot of fear with all of the diseases. And so how do we move beyond that? At the same time, I think if you've done any of the anti-DEI readings, there's a tremendous correlation as to what we're trying to do here today with these diseases. So if you can talk about that, and if you can't, I truly understand.
I think there is overlap, and I think a lot of the cultural factors that influence the health and well-being of people in the United States are, are driven by some of the social determinants of health: racism, discrimination, poverty, homophobia, transphobia. Those factors that can be ingrained and manifest themselves in different ways can directly influence access to care, and some of the disparities that we're seeing in our health outcomes. I think in some ways we can do better even within that framework. So I do think that so we've had some successes even as the whims of society or politics change over time. And some of that is that there are things in our control about which we talked about, making sure that you are documenting where you want to put your resources, making sure that the populations that are most affected, you're focusing your efforts, engaging communities and partners who are working with those groups instead of not doing that. And then I think you can make a difference. The way upstream, that often feels helpless to people who care. It feels really big. But I did want to put in some of those big examples because they were places for movements. People really, we highlighted those efforts and we made them happen our ancestors did for some of them, sometimes more recently. And I think that we can't give up on thinking about that and sharing that information, and then documenting whether it's working or not, because we have to be honest with ourselves too. So I am concerned about some of the changes in how society has been approaching some of the areas, and some of the kind of embracing of communities that has been really encouraged in common parlance and conversation and communications is now kind of harder to do and perhaps under threat. But we have lived through this before. Jesse?
I think we have another question.
Hi, my name is Cody Knight, and I'm with Southern Plains Tribal Health Board. But 30 years of expertise got me because I was going to ask about surveillance. But a pivot on that would be that you mentioned populations that make up 5% of the United States, or when we're looking at American Indian Alaska Native data, a lot of times that's either suppressed or roped into the other categories, and a lot of us work in those realms of trying to allocate our resources effectively. So can you talk to us about some efforts around that to make that piece of the data more accessible? Because person, place, and time is such a big part in a lot of our work. And so we want to get to that point.
I really appreciate your question. So first, sometimes if it is a small group that can't be analyzed alongside the large numbers and other, we can add years of data together and write a special report. So we've done that for a lot of different populations. And actually we can support others to do it too. So if you're a tribal nation, we can support you, and we have tribal epicenters and other, which we don't run out of my center, but are supported by another part of the agency. We're trying to work with communities to be able to look at their own data. And often that can be richer data than what you can get from kind of a standard surveillance form. The other is that once you're conscious about a disparity, so that concept of rate and number is like, it's forever our life. I mean, this is what happens all the time. It's like, yes, the majority of people who, I'm trying to think of a good example. Well, the majority of people with HIV are not African American, but African Americans are much more likely to have HIV. So you can have a very small group, but there's a big disparity. And so because of that, we need to actually count that. It needs to matter for us because the disparity matters. And then you need to be able to think, what can I do to make that disparity shrink as much as possible? And sometimes it's very focused efforts. It's not having the whole nation, it's actually working with the communities that are really affected. And I think then you can make a difference. I'll just highlight that we will soon be putting out a supplement looking at the broader, I would say here, for syndemic health among transgender women, where we did a special survey in our national HIV behavioral surveillance system that looked at a variety of different factors for transgender women, and it gives kind of a comprehensive approach to some of the areas that would have been either not as detailed or not as expansive if it had been part of another program.
Hi. So I really appreciate always when you present, Dr. Mermin, sorry. I'm Laura Pegram from NASDAQ. I guess I also really appreciate one of the things that is a through line in a lot of these presentations now that wasn't many years ago was this need and recognition to break down silos. And so I guess I will say I've been very impressed over the last many years how that, the acknowledgement that needs to happen at every level, even at our federal level. So I know you have the longest acronym at the whole CDC with all of those silos already put together with those syndemics. But I guess I'm curious if you can speak to any other efforts to coordinate across different centers and with different federal agencies.
Yeah. I think so that inside baseball, we don't want to talk too long about it, but I would say, only because it's going to bore everyone, but I would say that, yes, there's been tremendous effort. I mean, I was fortunate enough to be the incident manager for the MPOX response for CDC for 5 months, and it was remarkable how that response at the federal level, both brought together different agencies, SAMHSA, FDA, HRSA, the Strategic National Stockpile, I mean, the ASH's office, all sorts of parts of the government that sometimes wouldn't be working together met regularly, very frequently, and shared information rapidly and actually worked specifically on some specific activities that have fruitful results. The other is that internal to it does force us to start doing better internal to agencies. I would always say that collaboration for collaboration's sake is a waste of time, right? You don't want to just get along and have tea. You want to come together and say, let's work together on something. And so with some specific activities, we have been able to do that a lot more. And this administration has, with a prior CDC director, started something called Moving Forward, which is pulling us together, thinking about some very strategic areas where we can do a better job. And I think the agency is strengthened under this Moving Forward framework. It's still a work in progress. But I also feel like a lot of the groups like NASDAD have the same issues. You've embraced the syndemic approach, but then you have some of the same issues with either other organizations or even internal in the organization trying to work together. And so it's what we can do. It's because we have to.
Thank you. Stephanie, do we have a question out there? And then we'll go ahead to Dina.
Hi, I'm Tim Jones. I'm the Chief Medical Officer in Tennessee. And there was a question over here, I think, about basically state politics and state policies and how they're affecting this. And Dr. Mermin answered it with a very politically correct answer, but I won't. I'm in one of those states that's basically taken a nosedive. Our legislature essentially purposely is refusing CDC funding for HIV surveillance and prevention for Title X, passing laws to basically, SAVE Act-related laws, actively doing things to impede our progress and ability to do things with these high-risk populations. I will say CDC, one of the very first slides that Dr. Mermin put up there was sort of about administrative and funding flexibility, really needed. And I will say that we got a lot of assistance from CDC in facilitating that kind of flexibility when they saw what was happening to us. That's been incredibly useful. We've had to figure out ways, since state is refusing to get this money directly, we're figuring out ways to be flexible with using our community-based organizations and getting them some of the funding that we were getting and convincing them and to really do a lot of the work that we were doing under the legislature's radar. And we don't have data to show what's happening because of all of these changes, and unfortunately it'll probably take a few years before we see effect in some of these longer-term diseases and issues, but I think the proof is going to be in the pudding. I know that other states are starting to deal with this, but it's really depressing. But it's nice also to have support from Dr. Mermin and his team, whom I think are doing a really good job. That was also an awesome presentation, by the way.
Thank you so much.
Jono, thank you again. You are so the right person to get us started. And that was absolutely brilliant. And thank you for reminding us of the cost saved when disease is averted. I'm Jesse Milan, the CEO at AIDS United, and we've known each other a long time, but thank you for reminding us of the cost saved when disease is averted, and also reminding us of the importance of Social Security, Medicare, and Medicaid. But I'm concerned that this may be yet another conference where payors are not in the room, and whether they're private or public, they should be and can be part of the solution. So how do you see that payors, be they public or private, can be advancing a syndemic solution?
Thank you so much, Jesse. I love hearing your proactive, thoughtful, challenging questions. So we've become increasingly interested in directly engaging the insurer community as a community to be engaged with. So, it in many ways came out of experience with hepatitis C treatment and pre-exposure prophylaxis treatment, where the costs were extremely high, and although there's different responses to that, partially because of the preventive services coverage that the Affordable Care Act has for PrEP, but it doesn't have it for hepatitis C. And it just reminded us that if you want to make a difference, often, well, if it costs someone $40,000 to get treated for their hepatitis C, it won't happen. As much as you bring information, help them get diagnosed and screened, provide them with support, even link them to medication-assisted therapy, all sorts of things. If it's out of reach, it's out of reach. And if it's in reach, then you get to do our normal work of saying, well, let's engage you and let's help you get through this process, and it can work much more effectively. So we've started to think about how we can more proactively work with commissioners of insurance in states. Private insurers, there are a consolidation, so there's only a few private insurers that cover most of the United States. And Medicaid and CMS directly. CMS is a really powerful tool for good, but often a lot of the decisions are made at the state level, and so we need to be able to think about that and work with our health departments and to learn from that. And then the other, I think, is data, is just doing some of the analysis. We just recently published an MMWR on hepatitis C treatment, and it just showed that of all the people who had been diagnosed with hepatitis C, so they knew they had it, only a third had been cured. I don't know of any other potentially fatal disease that's like that. And I think it's because some ways hepatitis C is ensconced in the stigma and discrimination we have for the people who are more likely to have it. Some ways it's because the cost of the drugs were so high that all these restrictions were put into place, and now essentially they haven't been removed. So, and we need to remove them because now that the costs are so low, and because in some ways you're not required to cover those treatments as an insurer in some circumstances. So I think it's a gap for our community. I think it's a gap for my center, but it's a gap for all of us. It would be a great place to start thinking about how do we kind of bring them into the fold and work with them, just what you suggested.